Good afternoon, everyone. We'd like to get started. My name is Dennis O'Neill. I'm the chair of the board, and I'd like to welcome the various parties in the audience to this, our December meeting of the Connecticut Medical Examining Board. For the members of the board, you have your packet that was mailed to you, plus several email additions to that packet, and there is an amended agenda which essentially reflects the same business as the agenda that you received in the mail, but I'd like to point that out. That's at your place as well. A couple of housekeeping items. We're in a different setting this month. Pay attention to the fact that you have a microphone, and in order to be heard on that microphone, you have to press the red button to the right of your panel. You'll see the red light go on and the light on your microphone go on. When you're not talking, just press it again and the microphone will go off. If I have difficulty seeing who's trying to get my attention, feel free to tap into your microphone so that I can hear you. I'll try to maintain a peripheral field of vision so I see waving hands, etc. First, I'd like to go into the agenda, and our first order of business is to approve the minutes from our November meeting. Do I have a motion for that?
I'll make a motion.
Do I have a second?
Second.
Okay, thanks. I do have a couple of edits. There are a couple of typos on page 2, and then there was, if you go to page 2 under 3A, I just want to change a couple of words. The second sentence says that the board asked if information could be provided as to the policies and procedures. I'd like to change that to the actions licensed institutions have taken in addressing the causes of the adverse events identified in the report. So I'd like to amend the minutes in that section only. Any other amendments to the minutes? If not, all those in favor. We typically, if you were not present at the meeting, we abstain from this vote, but I'll ask for a vote. All those in favor of approving the minutes as amended, just signify by raising your hand. Anyone opposed, abstained? We have Trish Loving and Dr. Lindberg abstaining. Okay, thanks. Now that we have that piece of business over, I'd like to update everybody on a change to the constitution of our board. Dr. Manahar, who had served on this board for over 10 years, has recently been replaced with Dr. Michael Lindberg, who's way down on the right, to my right, and we welcome Dr. Lindberg. Dr. Lindberg is chair of the Department of Medicine at Hartford Hospital, and we certainly welcome him and his expertise to the board. We're also going to recognize Valandi by sending him a thank you for his many years of service. And I understand that Valandi has requested to stay on as a non-board panelist, and I would certainly support that. Okay, that brings us to chair updates, and I'm working off your main packet here. You have the monthly hearing assignment roll. For your information, we also have the case tracking chart. There are 9 cases on this. It's never been that low in the 10 years that I've been on the board, so we thank Donna Brewer and her staff and all those who work so hard to process these cases through. There are currently 9 cases. One of those is coming to us in the form of an MOD today, so it may go down below 9 in the month to come. I received in the mail a request to attend an educational session. This is from the CPEP folks out in Denver, Colorado. I think it was actually addressed to Jeff Cardis as the board liaison, and I just bring it up as an informational item. The CPEP is having an educational session for board staff in February, the first week in February. Jeff, I'm not sure, are you planning on attending this? Anyone who's interested in seeing this or attending, just let me know. From the Federation, we have a number of things. The news line was mailed to us, and the only thing I'd like to point out there is there's a Massachusetts task force to study the issues surrounding medical spas, and that's highlighted in this news line. There was also an article that was emailed to us by the Federation that was printed in the AMA News about that Massachusetts task force, and that's for your information as well. Then from the Federation, we have the BoardNet news from November 30, the BoardNet news from December 7th, and BoardNet news from December 14th. In the December 7th one, I just want to point out one item because this was sent to you in your packet. The Federation participates in a panel on physician professionalism. We probably all received an email from Dr. James Thompson, who's the president of the Federation of State Medical Boards. And in that email, he spoke about a meeting he attended where they discussed this article that came out of the Annals of Internal Medicine about professionalism in medicine. And it was the results of a national survey that showed that physicians frequently know what the ethical and professional standards are, but less frequently do they actually behave in the manner to which they subscribe. So I thought this was an interesting article. Everybody has a copy of it, and it makes for some good reading, particularly for physicians and non-physicians who sit on a medical board. Then also from the Federation, we again received a request for the scholarship program for the annual meeting, which is May 1 to 3. I think Dr. Hanks is planning on attending this, and Jeff, I'll pass. Oh, you've got a copy? Okay. So Dr. Hanks can fill out the appropriate forms. Jeff, by the way, here are the edits to the minutes. Okay, that brings us to information updates from Department of Public Health. Donna Brewer.
I have no update for the department.
Okay, thank you. Thanks. Jennifer, nothing? Okay. Next item is update from the Medical Society, Connecticut State Medical Society. I'm not sure if anyone's here from the society. No one is recognizing themselves, so we'll pass over that item. Now, I've taken the liberty of rearranging the agenda a little bit today. We're going to, well, actually, this is reflected on your new agenda. We're going to do legal office business first. So that brings us to 3A, Dr. Richard Glisson, petition number 2007-0215-001-026. For the department and respondent?
Respondent is not present.
Not present and not
represented.
Is respondent represented, but the council is not here?
I don't believe he's represented.
Okay.
But he's aware of he was aware last month that it was being presented.
Okay. Now, Dr. Glisson's case was presented briefly last month. The board members may recall that we tabled this in order to receive additional information about his medical history because some questions arose about his medical history, and you had a new front sheet to this case that was handed out to you right before the meeting. Does everybody have that?
Dr. Neal, if I may, last month there was a question asked to Dr. Glisson's medical history. Specifically, there was an interest in the circumstances related to the stroke that we indicated in the cover sheet. There was an error in the cover sheet. It says that he suffered the stroke in 2006. The fact is that the stroke that's corrected in this month's cover sheet, the stroke that took place in November 2001, and I do have in my file and some information sort of abstracted in the cover sheet for your information, the fact that he was evaluated by a neurologist at that time, and then he was evaluated again in October of 2003, the conclusion of that neurologist evaluation was that he recovered well from what had happened in 2001. And then in terms of the prescribing that he engaged in 2006, the self-prescribing, there was a separate substance abuse evaluation which concluded that he did not have a substance abuse problem, all of which provided guidance to the department in terms of the remedy that is set forth in the consent order, which is typical of what we do in cases where there's some bad prescribing practices but no evidence of substance abuse on the part of the individual practitioner himself.
Okay. For those of you who are trying to remember the discussion last month, I believe Dr. Bridberg was the one who spoke about or had questions about his medical history and was wondering if the history of stroke in some way created an organic brain syndrome or some kind of neurological deficit that predisposed the practitioner, to these prescriptive practice alleged violations. And it looks like what Stanley is telling us is that he was neurologically intact after that stroke. You'll recall that this was prescriptive practice issue for which we are being asked to sanction Dr. Glisson with a reprimand and coursework in proper prescribing practices, and this sanction, if we vote to do it, will be reportable to the data bank. Do we have any questions? David?
No, I'd like to make a motion to accept the consent order as proposed by the Department of Public Health.
Do I have a second? Okay. All right, thanks. Do we have discussion on the motion? Dr. Hanks?
Mr. Chair, I'm recused from this discussion and vote because of personal knowledge of this situation.
Okay, thank you. Any other discussion on the motion? We have a motion to approve the consent order as represented. Okay, I'll call the vote. All those in favor, just signify by raising your hand so that Jeff can see. Anyone opposed, abstained? Dr. Lindberg, and recused, Dr. Hanks. Okay, thank you. All right, that brings us to Dr. Scott Winikoff, petition number 2004-0624-001140, modification of a consent order. Just hold on one sec. Until I sign the previous one. Okay, thanks. For the department, again, we have Mr. Peck, and respondent is not present or represented?
That's correct.
Okay. Now, some of you may remember Dr. Winikoff because we have seen him here before, and what we are being asked to do today is modify a consent order from 2005. And you can read for yourself what the issue is on the front sheet there, but if you refer to page 11 of 14 in the previous consent order, you'll see the issue at hand. Apparently, Dr. Winikoff is not currently practicing in Connecticut, but he is practicing in the state of New York. And if you look on page 11 of 14 under number 10, it has a phrase there, or is employed outside the state of Connecticut, and this has to do with the time that elapses as part of the CO. And so, Mr. Peck, you can explain this as well. I'm just trying to direct the attention to the relevant segment, because Dr. Winikoff apparently is asking us to delete that phrase. Am I right?
Well, he's looking, yes, effectively that's what would happen here, because almost from the time that Dr. Winikoff entered into the consent order, he has been practicing in New York pursuant to a similar agreement that was put into place there, and has been in compliance with all of the terms and conditions of the order itself, the screens, the therapy, the employer reports. But because there's a provision that would effectively toll the time period of the probation for service outside, it's really intended to address primarily periods of time when the person is not practicing at all, as a reflection of the fact that you're not going to get credit towards your probation unless you do the full 5 years of whatever it is that you're being asked to do. He, in fact, is doing those things, but he's just not doing them in Connecticut. So he's asked for some recognition of that towards his period of probation. It was 5 years, which will complete in March of 2010, so he still has a little ways to go. And assuming he continues to practice without incident in New York, he could complete his full period of probation in that state.
One of the reasons we typically put that in a consent order such as this is because we're not always aware of what's going on in the other state in which the practitioner may be practicing. And you seem to be confident that you know what New York is, how New York is monitoring him, but I need to ask the question, how do you know what New York is thinking at all times? In other words, are you waiting for an offense to occur in New York, or is the department in regular communication with New York about this case?
My understanding is that we get regular reports from them that he's in compliance with their order and that is consistent with what our order is, and so we have no reason to believe that we have every reason to believe that it's effectively the same as if he was working here.
I see Kathleen raising her hand from behind you.
Anderson is our monitoring person, and she gets regular reports from New York on all of the issues: therapy, urine screens, employer reports.
Okay.
Right. I spoke to Bonnie an hour ago, and so far as she knows, everything is fine in New York.
Okay, so the department has no issue with this.
No, we don't.
With this modification.
We support this.
Okay. Questions, or can I have a motion? Yeah, Dr. Fuller.
I have a question about this. I wonder if this wording needs to be adopted going forward to leave room for this kind of person, because I dislike modifying things that have been settled for so long and have been working fine. But I understand this guy's predicament in that he's meeting all of the pieces of his supervised practice screens, et cetera, in New York. Is it something that we can craft better so that we can leave room for this kind of thing without having to change it 3 years from now?
We are working on some new language that will hopefully better address this issue. If we had known at the time that we proposed it to you that in fact was what his plan was going to be, we would have addressed it at that time, and we would not have had need to come before you with this. But yeah, we have some new language in the works that hopefully will better address this.
Okay. Other questions? Can I have a motion?
I'll make a motion, Mr. Chairman, to adopt the modification of the consent order as proposed by Mr. Peck.
Second.
Okay. Is there any discussion on the motion? I'll call the motion. All those in favor, just signify by raising your hand. Anyone opposed? Abstained? Recused? All right, it passes. Thank you. All right, going back to our agenda, I just want to skip down to 4B, assignment of a hearing panel on the issue of Dr. Matthew Giles. Jeffrey, we all taken care of in that respect?
Yes, Dr. Wolf and Mr. Erickson have indicated they'll serve on the panel for that hearing, and then we will select a non-board panelist for the third spot.
Okay. All right, good, thank you. And we don't have any time extensions, am I right? Okay, that that brings us to 4A, oral argument on the proposed memorandum of decision on Dr. Charles Jones, petition number 2004-0917-001-221. Now, I'd like to make a few comments before we hear from the parties. Well, first, why don't we introduce the parties so everybody knows who everyone is for the department?
Certainly, thank you. Good afternoon, David Tillis, staff attorney for the Department of Public Health.
And for respondent?
For respondent, Elliot Pollack. With me is my colleague Christine Collier, and Dr. Jones is sitting. Oh, pardon me, Dr. Jones has come up to the bench. Thank you very much.
Okay, thank you. Most of you know this from prior discussions on this case, but I am recused on this case, so I will conduct the discussion, but I will not participate in any substantive way in the facts of the discussion. So you will not hear any analysis from me. I will just be calling on people as needed. So I just want to reiterate that, and obviously when it comes to a vote, I will recuse myself. Having said that, I'd like to just point out that I have received several letters in hard copy and several email letters related to this case, which I have not read, but which I am now going to pass to the Assistant Attorney General for her file.
Jeff, do you know if this is something that you've already given me? And the reason I'm asking that, Dr. O'Neill, is because we do have a packet of letters and emails from the public that's going to be marked for identification only as a board exhibit. This will be board 44 for ID only. As of right now, there's 140. That number may change whether or not, based on whether or not Jeff determines or can determine that what you just handed me has already been received. I'm also going to be marking as board exhibit 45, a full exhibit, the order regarding the time allocation for oral argument by the parties. Attorney Pollack had requested an hour. The normal course is 15 minutes, and the board is allowing each side 30 minutes.
Okay, thank you. Before we get started, I'd also like to welcome Dr. John Seneschal, who is to my left, three folks to my left. Dr. Seneschal is a non-board panelist on the panel that heard the Dr. Jones case. Dr. Seneschal is a former physician executive and actively practicing pediatrician, and we're happy he served on the panel, and we're happy he's joining us today for the adjudication of this case. So welcome, Dr. Seneschal. As Attorney DiMattia said, each side has 30 minutes to put forth their oral argument, and I'm not sure which side. Do we have a predetermined arrangement between who's going to go first? Or
Well, normally it's the proponent of the decision, but both sides actually want modification. Right. Attorney Pollack had seemed to anticipate a rebuttal. Do the parties have a preference?
I had received an email from you yesterday that I would be going first, but it doesn't really matter.
Okay, that's fine with us.
Unless you really strongly prefer to go first. It makes no difference to me.
I would prefer to go first, but I'm not going to be too strenuous about it, because as long as I get my 30 minutes, that's more important than the order of presentation.
Attorney Tillis?
I'll leave it to your discretion. It makes no difference to me.
Okay, well, why don't you go first?
All right.
Okay, before you start, David, I just want to note that I'm adding 5 additional pieces of communication to what's marked as board number 44 for ID. So that's a total of 145 documents. As you can, thank you.
All right.
Okay, Attorney Tillis?
All right. Well,
we have a proposed MOD before us today. What would you like us to do with it?
First of all, thank you to the panel. I think I speak on behalf of Attorney Pollack and Attorney Collier also, that your patience, your guidance, your humor, your questions helped a long and sometimes difficult process. And certainly as an attorney presenting a case, I appreciated it. And welcome to Dr. Lindbergh. You stepped in on your first day in an interesting situation. In general, the department supports the proposed decision. There are 3 modifications we would like you to make. One is a modification to paragraph 4 concerning the monitoring. One is a modification to findings 11 and 16. And then regarding findings of fact 8 and 15, we'd like you to change that so that in fact it's a finding in favor of the department. I'm going to address the first 2 modifications first and speak for a time about the respondent's position in its brief, and then proceed to the request that you actually change the proposed finding of fact, because I think that will flow from my discussion, an overview of the case itself. The modification that we request with regard to paragraph 4 comes in 2 pieces. We would like you to specify that the practice monitor who reviews the charts be a board-certified pediatrician. We have in fact been doing this more and more in consent orders, where the monitor would be board-certified in the field of practice, and we think it's important that a monitor be chosen who in fact has the experience and the training to review charts in the field at issue, and the best indication of that would be board certification. We would also like in that modification sort of a tightening up of the time element. The proposed decision is that a candidate would be nominated within 60 days, and we'd like it to state that the first review will occur within 60 days. In other words, that the nomination and approval process move along and the monitoring process begin promptly. And we think the findings of fact and the conclusions in the proposal, even without the modifications that we asked for, show a need for a prompt attention to the respondent's charts. And that's why we asked for that particular time limit. And the third aspect of paragraph 4 is perhaps a little thornier, and it's a little bit unusual, but it's not unprecedented. And that is in subparagraph 3, where it talks about the monitor and the report that the monitor is to file. And the monitor is to file a report which states that based on his or her review, the respondent is practicing safely and effectively, and that's the usual language. But we'd also like it to state that the respondent is practicing safely and effectively and in compliance with the standards enunciated in this decision. Obviously, there's been a lot of controversy over this period of, 10 or 11 hearing days as to what the standard of care ought to be or is. And I think by enunciating and specifying to the practice monitor that the charts ought to demonstrate compliance with the standards enunciated in this decision, it provides some guidance and avoids future disputes. There is some precedent for this. The board has specified in its memorandum of decision in other cases particular criteria or parameters for a monitor. For example, in the matter of Enrico Koo a few years ago, where the board imposed a period of probation with the chart review, and part of the chart review is to review all prescriptions of controlled substances, and it set forth 6 specific criteria that the reviewer was to examine and report about in that case. So it's really a tool to lend some clarity to the monitoring process, really in order to avoid disputes later, precisely because there has been a dispute already about what is and what is not the applicable standard of care. So that's the purpose of that request. In regard to facts number 11 and 16, that's a pair. One is to patient S and the other to his sister, patient E. And both find that with respect to testing done in April of 2005, laboratory test that came back completely negative, that respondent failed to reconsider his diagnosis. There's no particular finding one way or the other that the failure to reconsider is a deviation from standard of care. It may be implicit in the choice of the word failure, but we'd like it to be expressed, just so there's no confusion. So those are the 2 modifications right up front that are really textual changes and not fact changes. I want to get to the meat of the case. And the meat of the case, it seems to me, is respondents' argument that the board has no business entering into a debate between two schools of thought. So let's look at that. The panel has proposed a decision that states a standard of care that I believe is the standard that, in fact, every physician uses in making a diagnosis. Always. Every diagnosis, every specialization, every shading of understanding about any particular illness. The panel says a physician deviates from standard of care when he diagnoses a disease when the exposure is extremely low, when the patient standing before the physician does not exhibit specific signs and symptoms of the disease, when the medical history is not specific, when the laboratory tests are negative. Well, I really think that's the process that physicians use. Always. There's nothing unique about it. There's nothing new about it. There's nothing even particular to Lyme disease about it. Respondent says it's a new standard, and the board has no business enunciating a new standard. Respondent says that a patient can have Lyme disease even if their laboratory antibody tests are negative. Yes, that is possible, although there is some debate about how often. Respondent says that a patient can have Lyme disease even with nonspecific symptoms. Again, the debate is that one group says that a person can be diagnosed with Lyme disease on the basis of nonspecific symptoms alone, and another group says that there will be, in a person who truly has the infection, especially at a late stage of it, one of 5 specific objective signs and often nonspecific symptoms. That's not unusual that an illness produces nonspecific symptoms. That's not the debate here. And I don't think it's ever been the debate. Let's assume that it's true that a patient with nonspecific symptoms alone can have Lyme disease. That hardly means that every patient with nonspecific symptoms has Lyme disease. And Dr. Jones concedes that in cross-examination because it's obvious. That's why the diagnostic paradigm is to look at the exposure, the symptoms, the history, the diagnostic testing. If there's no exposure, if the symptoms and their history could have several etiologies, if the laboratory tests are negative, what is the basis for diagnosis? I suggest to you that the respondent's brief misunderstands this petition. When the department has argued over and over that the part of the petition that pertains to diagnosis is about diagnostic method and not about the particularities of Lyme disease, that is exactly what the petition has been about. That is what the allegations stated. That is what the evidence stated. That is what Commissioner Galvin stated in his letters to Attorney General Blumenthal. And I think that's what the panel has stated. Let's look a step deeper. As I understood the evidence, nobody except Mr. Pollack and Dr. Jones have ever said otherwise during the hearing. Dr. Fallon and Dr. Phillips testified on behalf of Dr. Jones. They also testified at various points in their testimony, direct cross questions from the panel, that Lyme disease was an unlikely diagnosis in a child with nonspecific symptoms who lived in a non-endemic area and had no evidence of actual exposure. Some important qualifiers there. Non-endemic area, no actual exposure. Dr. Seneschal, during the course of the hearing, noticed a pattern in S's records, that his symptoms, his emotional and behavioral symptoms, seemed to rise and fall according to the flow of contention and resolution between his divorced parents. He suggested to Dr. Shea, who again was Dr. Jones's expert as a psychologist, that the primary diagnosis for S should have been anxiety. And Dr. Shea agreed that he would also have looked at it that way. Now, respondent offers, as part of the appendices to his brief, and indeed their evidence, their exhibits and evidence, some documents in support of his position. And I'm going to look at 2 of them, even though he offered many, because I think these are 2 that are really at the core of the documents that he claims supported his position. One is a publication from an organization known as ILADS. I think I somehow always manage to get this wrong, but I think it's the International Lyme and Associated Diseases Society. It's Exhibit 18, it's Appendix A18, Section 18 of it says the differential diagnosis of Lyme disease requires consideration of both infectious and non-infectious etiologies. It goes on to list several, all of which would require testing or focus examinations. Excuse me. It says also in section 15 that the physician must look to the history of exposure, known tick bites, rashes, or symptoms consistent with Lyme disease must also be considered. Dr. Joseph Borreliosis is the author of an article in Cons in 1997 on the diagnosis and treatment of Lyme disease. He's a prominent practitioner who specializes in Lyme disease. And his writing was Exhibit V-10, it's Appendix A-17. He writes, the diagnosis is a clinical one based on the type and pattern of symptoms present and their evolution over time, especially in the setting of a previously healthy patient who has had potential tick exposure. That is no different than the standard that appears to be used in findings 7 and 14. Exposure, symptoms, history, serology. It's a complex. And if none of them is indicative of the disease, how can you make the diagnosis? I don't see that there's any choice here between two conflicting schools of thought. There's an overarching principle of medicine that applies across the board. And really, nothing in the guidelines and the literature of practitioners who practice like Dr. Jones contradicts it. So I would say that the core argument that the respondent raises all along simply misunderstands the case. Now, I want to take a look at the case, and I want to start out by looking at a few facts sort of outside of a narrative flow, because they pertain directly to some of the things we just talked about in Dr. Borreliosis' writings. First of all, S was not previously healthy. Many of the symptoms that were in his history as presented to Dr. Jones, he'd had for many years. Neither child had ever lived or traveled in an area where there are populations of the Ixodes scapularis or the Ixodes pacificus tick. It's not just any tick that carries the Borrelia burgdorferi spirochete, only those two species. And neither of those species can live in an arid climate. These children lived near Carson City, Nevada. They'd lived there virtually all their lives. S had been born in San Diego. They'd lived and traveled in arid areas their whole life. And it's not some obscure entomological piece of knowledge about the distribution of ticks. The CDC has published a county-by-county map of the whole country showing the location of Ixodes populations, and they've done this since the mid-1990s. The only report to Dr. Jones of a tick bite was a partially attached, non-engorged tick that occurred on a vacation trip. Let us assume that it was an Ixodes scapularis tick, in spite of the geography, in spite of the great difficulty that non-entomologists have in identifying them. Let us assume further that it was an Ixodes scapularis tick that actually hosted this particular spirochete, even though, again, the evidence shows that outside of a few regions of the country, the percentage of ticks that are hosts is very low. Here's the key. It's a non-engorged tick. It can't transmit the bacteria until it's engorged. The bacteria lives in the tick's gut. All of this was explained during the course of testimony, and it does not leave the gut until the tick has had a nice meal of blood. There can't possibly have been an exposure through the tick, and indeed the very tick attachment in issue appears to have been the tick attachment that's discussed in an emergency room record that was provided to Dr. Jones before he ever treated the patients. And in that record, the examining physician at the emergency room specifically notes that there was not an erythema migrans rash, the pathognomic bullseye rash. Now, it may be that patients can have Lyme disease and not have had the rash, but a negative report is hardly supportive history. So what do we have? Dr. Jones also stated in his charts and in his correspondence with S's school officials and in his testimony that the children had been exposed during gestation. On cross-examination, however, you can see that there's not a single published report of a child born with a known infection who developed a diffuse disease condition many years later. The reports of fetal infection were of stillbirth or massive malformation. Further, Dr. Shapiro pointed out that there were no findings in those instances of inflammation and no patterns of malformations in the reported cases, such as one might find in a child born with congenital syphilis, casting doubt on the spirochete as the cause. Large-scale studies, for example, at Children's Hospital of Philadelphia, published by Dr. Stephen Epps in 2002, concluded that while the spirochete can transmit transplacentally, there is no evidence that it causes Lyme disease, no matter how one defines the disease. So there's no exposure. What are we left with? The lab tests don't show the exposure. What are we left with? So what's the case? I'm going to skip over the prescribing of the Zithromax in March of 2004. Respondent hasn't objected to that finding. I'm going to skip over the part about the respondent making recommendations to S's school psychologist that because he had Lyme disease, he should be home tutored for the remainder of 5th grade and all of 6th grade when he'd never even examined the child. Respondent doesn't seem to object to that finding either. Let's look at the case itself. 2 children, a brother and a sister. The boy's 11, the girl is 9. Their mother, Robin, called Dr. Jones in December of 2003 upon the recommendation of the doctor in Florida who had just diagnosed her with Lyme disease. She was worried that the children also had it. More particularly, she was worried that they'd become infected from her during her pregnancy, and she also recalled some tick bites a few years earlier. She called Dr. Jones a few times in December and January. Based on her calls, Dr. Jones made a presumptive diagnosis of Lyme disease, scheduled an examination in May, several months out. At the end of January or the beginning of February, Robin sent Dr. Jones a copy of the children's charts from Dr. Robert Kimmel, their pediatrician in Nevada for the past 5 years, as well as charts covering the period back to the mid-1990s for various hospital services for both children and various psychiatric and psychological services for S. These charts contain the mother's responses on the history questionnaire. The questionnaires for both children list virtually every condition on a list of 39, excepting only sexual dysfunctions and alcohol. Pelvic pain, joint pain in nearly all the joints, chest pain, heart palpitations, urinary incontinence, testicular pain for S, rashes on E's, thighs, and buttocks, vertigo, confusion, hair loss, weight loss, tremors, headaches, nightmares, and so on. Robin testified that these had been going on for years, and she testified that she told all of the history to Dr. Jones, and Dr. Jones reflected that history in his discussion of his care for the children. So what is a prudent pediatrician to do with this history? Well, let's start looking at what Dr. Jones did. He examined the children, a general review of systems, without any particular focus. He sent blood samples to a laboratory in California for a Western immunoblot test for antibodies to Borrelia burgdorferi, the causative bacterium. That was his whole exam. He diagnosed them with Lyme disease, and he prescribed amoxicillin. Then the children returned to Nevada. There was no physician there who monitored them. Dr. Jones knew that. They were on amoxicillin for a year. No one monitored them. He said he trusted the mother, but then he also said that in any event, he and the mother had attempted to arrange pediatric care for them in Nevada, but their father threatened the physicians there, and they declined. Very specifically, he testified that Dr. Kimmel and then later Dr. Michelle Kelty at a different office told them that their father, Jeff, had threatened them both. In fact, Dr. Kimmel testified that not only had he never been threatened by the children's father, but that he'd never had any communications at all with Dr. Jones. Dr. Kelty testified that she never told Dr. Jones that Jeff had ever said anything to her at all. In fact, Dr. Kelty testified that she'd never spoken with him. So, that's kind of the course of things. What else did Dr. Jones know when he examined the children in May of 2004? He knew that all the charts that Robin had sent him completely contradicted the history she gave. Now, I need to emphasize, and it's borne out by Dr. Kimmel's testimony, that it wasn't a difference in interpretation, it was a difference in observation. That the long list of complaints had never been presented to him. He'd never seen these symptoms. In fact, in S's chart, there's an annual physical from a few months earlier with a completely charted review of head to toe. None of these symptoms present. There's no question that S had behavioral problems at school, and it became worse during 5th grade. I'll come back to that in a moment. There's also no question that in December of 3, at Dr. Jones's recommendation and at Robin's request, Dr. Kimmel sent some serum samples to medical diagnostic laboratories in New Jersey to test for Lyme disease and other possible tick-borne infections, and they were completely negative. There's a debate about threshold of positivity, just exactly what does and does not constitute a positive result in various labs' interpretations. Let's leave that debate out. Those tests were completely negative. Dr. Jones had a copy of those tests before he saw the children. The subsequent tests that Dr. Jones did were negative by the standards of the laboratory that reported them, and Dr. Jones says he chooses that laboratory because it is most likely to find an antibody response of all the labs he knows. Nonetheless, the lab reported the test as negative. Dr. Harlan, board-certified pediatrician, Dr. Shapiro, board-certified in pediatrics, subspecialty board in pediatric infectious diseases, both testified as to what a physician ought to do under these circumstances. They testified that a more focused inquiry should have been made as to many of these symptoms, even if the children had Lyme disease. It doesn't necessarily explain all of the symptoms. That urinalysis was an obvious choice for the complaints of pelvic pain, of urinary incontinence, a complete blood count. Since the children complained of visual and auditory problems, an examination in detail of sight and sound, a more extensive orthopedic workup for the joint pain. Dr. Jones did none of these things. Dr. Fallon's writings and in his testimony, he talks about how you delineate or how you differentiate anxiety, the somatic symptoms of anxiety, from the symptoms of Lyme disease. Dr. Jones did not do those either. Dr. Jones testified that the way he differentiated anxiety from Lyme disease in this case was solely on the basis of exposure. Yes, he mentioned in passing that a few thoughts occurred to him as he was interviewing them, as he was interviewing the children. He gave them some thought and rejected them, but he never did anything actually to differentiate other than look to the exposure. We know there was an extremely low exposure here. So what did he do to differentiate? Nothing. He listened to the children's mother. He said over and over that whenever there was a contradiction between the documentation and the mother's history, he relied on the mother's history. I submit to you that as a general method of diagnosis for any condition, that is not an effective method of diagnosis. That a prudent physician must carry out an effective differential diagnosis in this situation and in situations like it, and he didn't. So, summarize it all. I think I have about 3 or 4 minutes left. 5, thank you. We would like the findings of Fact 8 and 15 to show that in fact he did not make a differential diagnosis. There may have been some passing thought about some other possibilities, but passing thought is not a differentiation. And that's the only evidence that Dr. Jones presented about a differential diagnosis. We'd like the monitoring to be clarified as to the qualifications of the monitor and the scope of the review. We'd like the findings about failure to reconsider to state expressly that they do not, that those are deviations from standard of care. One last point. Respondent in his brief claims that the remedy here is disproportionate, and he gives you 3 consent orders as illustrations of cases where the outcome was worse and the remedy was milder. Those are consent orders. They're allegations without admissions. There are no findings, and as the board well knows, that process is a process of negotiation where the quality and quantity of the evidence weighs heavily. Here we have findings. We've conducted days of hearing. There must be a stack of transcripts and exhibits yay high. It's not a question of weighing the evidence and coming up with a compromise. So I'd ask you not to be persuaded by that. There's also in respondents' package a decision from New York. You're not bound by it. and indeed there were some pages left out. Most of the findings the New York board made were very similar to this panel's findings. So, and much of that case had nothing to do with Lyme disease. So, I think respondents' position completely misunderstands the case. The department has never asked the board to take a position in the debate between two groups of physicians. We have asked the board to apply broad principles of medical practice. It appears that the panel has done that, and we think that the remedy proposed is a fine remedy given the findings and other than the changes we've asked for. So thank you again.
Thank you, Mr. Tillis. Attorney Pollack, you have 30 minutes.
Thank you, Dr. O'Neill. Let me say at the outset that I'm not going to touch on every issue that I raised in my brief because the purpose of oral argument is not to do that. But of course, all claims raised in the brief are reserved, and I hope that you have had a chance to read the brief, pardon me, as well as to review the applicable pages of the appendix, which were exhibits introduced during the case. Well, a father involved in post-divorce decree custody litigation complains to the Connecticut Department of Public Health that the Connecticut physician treating his son and his daughter for Lyme disease is not doing right by them, and that his children don't have the disease. He also attacks the mother's, his former wife's, competence and credibility. The mother, who came here to testify, by the way, an immensely credible and devoted parent, who is also a registered nurse and a certified EMT, tells the hearing panel how ill and behaviorally challenged her children were for years, especially the son. The children were born in San Diego, which is a Lyme endemic area. Just came back from there. There are signs all over the cliffs. Don't go in here. They're Lyme ticks. They did grow up in Nevada. The children were exposed to Lyme on vacation, she testified. The medical records indicate tick attachments during an ER visit. They were not being helped by anybody in Nevada. The son was threatened with expulsion from school because of his behavioral problems. After many efforts to obtain medical assistance within a reasonable distance of her home, and after being treated for Lyme disease herself, she tells her children's problems to her physician, who recommends that she see Dr. Jones. They're seen several months later in New Haven for approximately 2 hours each. Dr. Jones diagnoses Lyme disease and treats them with antibiotics. They are seen again about 11 months later, discharged from treatment. They are cured. They show no further symptoms. They are both doing well at school. And by the way, I might note the two children were here as well. The department never even raised a finger to have any kind of examination, request an examination of the children while they were here. Prior to seeing the children in New Haven, Dr. Jones renews a Nevada caregiver's script for Zithromax to treat one of the children's upper respiratory infections. The mother explained the circumstances at the hearing, which motivated her to ask Dr. Jones for the renewal. Won't go into all of them here, but she explained why it wasn't available, the numerous court appearances she had been forced to go to against her husband in these post-divorce proceedings to get him to pay the bills. Dr. Jones did not diagnose or treat either child for Lyme until he saw them in New Haven. He conducted a very extensive physical examination, took their histories, and made his diagnosis. He did reach a provisional diagnosis in his mind during his telephone conversations and interactions with the mother prior to the kids coming to New Haven. But so what? Don't many physicians do exactly the same after that many years practicing? Isn't it logical to start thinking about what the kids might be presenting with before they actually come to see you? He was honest enough to concede it, but it's of no moment here at all. And indeed, after so many decades of practice, with a man with his talent and thousands of patient encounters behind him, what is wrong with that? Wouldn't we like our doctors to have the skill to be able to start thinking before we show up in their office too? Hippocrates, of no less a personage than him, whose oath still forms one of the ethical planks of your profession, doctors, stresses the art of the diagnosis. What they want is hard stuff. What we're talking about is both hard stuff and art. Who is to cast the first stone to say that Dr. Jones lacks the experience and skill to reach a provisional diagnosis after spending that kind of time? And who's to say that such a conclusion, preliminary, tentative, prior to seeing the children in his office, should generate any discipline? Why on earth should it have any relevance here at all? So before coming to New Haven, it is undisputed the mother contacted Dr. Jones to seek his input and assistance about the threatened expulsion from school. And Dr. Jones did speak to the principal, and he told his principal how these situations are frequently resolved without expulsion. I'm not going to discuss the medical allegations for a moment. I'll get to them later on in my remarks. First, I want to just discuss the merits of the peripheral issues, so to speak, the ones that the department has loaded into the statement of charges to achieve its disciplinary goals. Under ideal circumstances and lack of parental capability, and I emphasize lack of parental capability, monitoring of patients under long-term antibiotic treatment, of course, is appropriate. Here, however, it's undisputed that the mother is a healthcare professional and a remarkably bright and clear-headed one. Is this board going to decide as a matter of law and precedent that it is a violation of the standard of care for Dr. Jones to have been comfortable enough with the mother to have her do the monitoring when they couldn't find someone else to do it out there? Of course, the children did very well. There were no problems. First example of an absolutely victimless series of allegations here. And I might say that both Dr. Shapiro and Dr. Harwin grudgingly agreed on cross-examination that the mother was qualified to monitor the children. So let's move on to the next one. The prescription over the telephone. What a major deal is being made about this. Dr. Jones admits that he compassionately renewed for one time a script issued by a Nevada caregiver. How many of you would care to guess how many times a physician in this state does exactly the same thing? Now, the department will argue on rebuttal, I suppose, that it's okay if a physician does that for a patient that he or she is familiar with, but not for a patient he or she hasn't seen before. Is this narrow distinction in this case, in this Lyme case, going to be a basis for discipline against Dr. Jones? I can't believe that the board would allow itself to be whipsawed by this department pursuing Dr. Jones over something so minor. And how many other physicians are they going to prosecute for the same thing? Now, was this charge included in the statement of charges against Dr. Jones because it was a legitimate charge, or just to load up with just about anything they could find to throw at him? Let's talk about the educational recommendation issue while you ask yourself that last question. The mother did reach out to Dr. Jones, as I said. The son was threatened with expulsion. The school system had initiated a study Mr. Tillis didn't refer to, which suggested he was on his way to expulsion. He was a major behavioral problem in school. In frustration and desperation, she calls Dr. Jones, "Can you help me?" He did interact with the school guidance counselor. He hadn't seen the kids yet. He did make an effort to do good. He did good. A homeschooling arrangement was agreed upon between the mother and the school. The child was schooled at home. When he returned to school the following semester, he did absolutely wonderfully. Are you going to punish him for that? In an era which physicians are all too frequently criticized for rushing through patient encounters, 2 hours with each child, stressing the dollar, and for practicing impersonally, this physician accomplished something tremendously important without even being paid for it by these consultations over the phone. Is that going to be a means of, is that going to be a cause for discipline here? Now, before we turn to Lyme disease, let's go back to the father who initiated this whole mess. He's the one who twisted the healthcare system's bureaucracy into bringing these charges. The record made it very clear that after many efforts on his part to wrest custody away from the mother and use his complaints against Dr. Jones for that purpose as leverage, when he lost his efforts, he moved several hundred miles away and hardly ever sees his kids anymore. Shameful. He is the complainant. The mother is not the complainant here. You didn't hear anything about the mother's dissatisfaction with Dr. Jones's care from Mr. Tillis. You didn't hear anything about the kids doing well, did you? Well, that's in fact what happened. So now let's try to shed a little light on the medical issues here. And I also thank the panel, although I seriously question their decision. I do thank the panel for their unsalaried, voluntary, and hard work in attending 11 days of hearings, and no doubt in reading lots of memoranda, briefs, and other papers that were thrown at them by both sides during the course of the proceedings. And I'd also like to thank the people who came to all the hearings who were very concerned about this case, because contrary to the department, It deals with Lyme. It addresses Lyme. In fact, you heard Mr. Tillis say he wants to make sure that the standard that Dr. Jones practices under this monitor is the standard that the panel has promulgated in this case. So let's not play any games here. This is a seminal case that deals with the standard of care for practicing Lyme. And isn't it poetic, in a very twisted way, that the monitor that they're suggesting be imposed to look at this man's practice after 30 years is not even someone who knows anything about Lyme disease? How perfect is the solution that they propose to a problem they don't understand and in which they are asking you to rule very improvidently? There's a very important issue that arises here, and it's a legal issue and it's a factual issue. The Department of Public Health Commissioner has given out many, many inaccurate statements as the leader of the department, and they bear on these proceedings very importantly. The Commissioner inaccurately represented to the Attorney General and to the public that DPH does not seek to tell physicians how to diagnose and treat Lyme disease. It's in your appendix. What's happening here? Just the opposite. He inaccurately told Attorney General Blumenthal that DPH accepted that there were differing views about Lyme disease, contrary to what you've been told here. And I'll tell you more about that in a minute. Inaccurately told Attorney General Blumenthal that the department would not attempt to establish a standard of care. What's happening here? Is this like a Japanese movie where some things are said on one side of the room and other things are said on the other side of the room? In fact, as anyone can tell from reading the statement of charges, as Attorney General Blumenthal pointed out to Commissioner Galvin, that's what this case is about. To challenge Dr. Jones's clinical care here and to say it doesn't pertain to Lyme disease, for those of you baseball fans, is like criticizing A-Rod's batting average and saying you're not talking about baseball. The hearing record is full of discussions of colloquy between counsel and panel members about this very issue. And let me just read, which you have those copies up there in the transcript of the hearings on June 22nd, 2006. Dr. Seneschal states, as he's talking to me at this point, you said that the crux of this issue is to determine the standard of care for Lyme disease. Now, that's not how I interpret it. I mean, this is not a forum to determine standard of care. This is not our purview. I mean, we can't determine the standard of care. I agree with Dr. Seneschal entirely what he said on June 22nd, 2006. That's not what happened here afterwards. Now, you may sit back and say, well, since Dr. Jones's attorney is saying that this case is about the standard of care, what does it matter if the commissioner said it wasn't, if the panel members didn't understand it that way, if the department's representatives argue that it isn't about the standard of care? No harm, no foul? Not true. The answer to that inquiry is that it's a fundamental denial of fair notice and due process under any constitutional question for an agency to say it won't bring charges and then do it. Public officials have to be scrupulous in what they say and honest in how they talk to us. Curveballs are not permitted in healthcare regulation or anywhere else. The public and clinicians are entitled to rely upon the public statements of their officials. How many other physicians relied on Dr. Galvin's statements here in their practices? How many other doctors will now be pursued by this department if this highly objectionable decision is not rejected entirely? How many other physicians practicing in different areas will erroneously rely on future DPH statements to their great detriment? We're living in some kind of Orwellian world, one in which a wholly inaccurate statement by the commissioner on March of 2006 is to be ignored. Let me quote the commissioner. The DPH continues to understand that within the medical community, there is not currently one recognized method of diagnosing this disease, nor one accepted treatment regimen. Scientific evidence is not yet available that the department would rely on as the single standard of care or best practice for patients with Lyme disease. Yet that they want Dr. Jones monitored to comply with the new standard that they proposed and that the panel more or less adopted. By the way, the statement of charges was filed in 2004. There's something seriously wrong in the state of Denmark when you read the commissioner's statements and you look at what's happened here. All right, let me talk about a little bit about the reconsideration issue. The department says that after getting the negative test back, Dr. Jones should have reconsidered his diagnosis. It's absolutely without foundation to charge him for violating that as a standard, so-called, as a result of a negative test. It staggers the imagination to understand how he could be guilty of anything, given the overwhelming evidence in this case that serology is not accurate. It's unreliable. There are many false positives and negatives. Panel members stated this. They understood this during the hearings. How could that possibly be part of the standard of care now? The differential diagnosis allegation. They hang very heavily on Dr. Shapiro, an academic with great credentials, I might say, who has probably treated fewer Lyme patients in his lifetime than Dr. Jones sees in a year. Apparently, his opinion that infection was an extremely unlikely cause here. He wasn't impressed with the tick bite attachment. He wasn't impressed with where they were vacationing when the mother thought they were bitten. He wasn't impressed with the fact where they were born. But, of course, that doesn't differentiate Dr. Shapiro from other physicians where the mother saw and could or would not help. It doesn't differentiate Dr. Shapiro from many other physicians who are dismissive of central nervous system symptoms and other nonspecific symptoms, which children demonstrate, or who demonstrate them, and they ultimately are found to be, they ultimately are diagnosed with Lyme. Dr. Shapiro, their primary witness, Dr. Harwin had no Lyme experience whatsoever, even though he was a pediatrician. It is obvious that Dr. Shapiro views the lack of specific symptoms as an equivalent of anxiety or a psychiatric condition. The classic response when you don't understand something. You're sick, but since I can't figure it out, you must be slightly crazy. He has dismissed the pain of hundreds of pediatric patients and has refused to see them due to this bias. Evidence to establish this from patients was not admitted by the panel. They wouldn't let us put on evidence on that. Now, Dr. Shea's testimony on behalf of Dr. Jones, mischaracterized. He didn't tell Dr. Seneschal that he didn't have the competence to make a diagnosis. He told him specifically he couldn't make a diagnosis of Lyme disease. He's a psychologist. He treats a totally different aspect of the problem. Dr. Fallon's testimony is mischaracterized. Let me refer to the very page that's footnoted in the department's, page 5 of the department's brief. It was testimony given by Dr. Fallon on November 16th, 2006, at page 97. It's a bit long, but I think it's important not to take anything out of context. If a child has had no exposure to ticks and no exposure to a Lyme endemic area, notice the qualifications, then Lyme disease becomes something probably you would not think about. On the other hand, if there was exposure to ticks and if there was exposure to a Lyme endemic area and a child has multisystemic symptoms, does it sound a little familiar? That are consistent with Lyme and has attentional problems that have emerged and behavioral problems that have emerged, then you have to wonder, is there something going on that's causing a central nervous system disturbance? Dr. Harwin also, in his testimony on March 23, 2006, stated, and I'm quoting him even though I dismissed him as not having Lyme knowledge or experience, he said Lyme would have figured in his differential diagnosis. Boy, we're really slicing the salami very thin here, aren't we? This is a paper mache issue, this differential diagnosis issue. It's especially problematic in view of the fact, as Dr. Jones well knew, that these kids had all received extensive workups from other physicians in Nevada, which failed to disclose any treatable problem. Why should he have subjected these kids to unnecessary tests? Why was it necessary for him to reconsider a diagnosis when his treatment was working? They rely on Dr. Harwin, who knows little or nothing about Lyme. Difficult to understand. If you read his testimony, it is clear there's nothing more than a Monday or Tuesday morning petty sniping at a successful outcome. Is our healthcare system really going to insist that a talented physician with years of experience and thousands of patient encounters who cured these two kids order unnecessary chest x-rays with the attendant radiation, order potentially invasive pediatric cardiology workups, and spend more than the 2 hours that he spent with each kid in developing his diagnosis? Is that where our system is heading? That's what Dr. Harwin wanted him to do. Let's talk about the issue raised in our brief about the ex post facto standard of care. As I said before, you've got before you exactly what everybody associated with this case on the department side has said they weren't trying to do. Aside from the questions of trust and candor that I think this board should grapple with. There's an important legal issue here. 7 years ago, in a case involving a Dr. Raxlin, this board was also asked to make a determination about the standard of care in another pediatric case involving Lyme disease. I don't know if any of the members of the panel were on the board then. Perhaps Dr. O'Neill was, I don't recall. Dr. Shapiro was the chief inquisitor in that case as well, coincidentally. The hearing panel refused to cooperate, and the board supported its decision. Now, I would maintain that it's fundamentally unreasonable, unfair, and offensive to due process for this board to promulgate new rules when it says it's not going to, apply them retroactively, especially against the backdrop of the DPH commissioner and the Raxlin decision. To me, it almost amounts to an ambush. This is especially true here, where if I think I'm correct in this, none of the members of the hearing panel had any experience, any significant experience diagnosing or treating Lyme disease, and I don't believe any member of the board, and I'm not sure about Dr. Lindberg. I defer. I have no idea what your background is, sir, but other than perhaps Dr. Lindberg, nobody else on this board, to the best of my knowledge, has any extensive experience treating Lyme disease. So you're depending on Dr. Shapiro here. He's got to be your guide if you decide the way the department wants you to go. Let's talk about nonspecific versus specific symptoms. Again, Dr. Shapiro, very constricted view of Lyme disease. He wants there to be swollen joints, Bell's palsy, or Lyme carditis. Otherwise, maybe a couple other things. Otherwise, you don't have Lyme disease. And by the way, you have to have the rash, pretty much according to Shapiro, although the literature shows that much less than 50% of the diagnosed population ever presented with the rash. So, in view of the Shapiro position, are you now going to, if you sustain this decision, are you now going to say that the ability of other physicians to diagnose diseases that present with nonspecific symptoms is also going to come under attack by those who want to go after people who seem to be doing things a little differently than they are? What about fibromyalgia, dismissed by the medical profession years ago as a psychiatric problem? Now, all kinds of literature about it. What about chronic fatigue syndrome? What about lupus? What about Alzheimer's? There are other diseases. There's so many examples in our history as a society of dissenters, nonconformists, clear thinkers, and mavericks who challenged the medical community and were ultimately proved right. Please don't stumble on this one. Their efforts, their contributions to medicine and society initially met with derision, rejection, ostracism, and legal prosecution. Lyme disease is only the latest. Remember ulcers? Medical profession always thought this was a psychiatric problem, drink milk and stay away from stress. Dr. Barry Marshall swallowed a couple of flasks of Helicobacter pylori in order to establish that it was caused by a bacterium. He was on the fringes of the profession, laughed at by everybody. What about fibromyalgia, psychosomatic illness? Spoke about chronic fatigue syndrome. Childbed fever by the noted Semmelweis, the Hungarian physician in the 19th century, was attributed to a fever. His colleagues laughed at him to the point where their rejection became such an obvious mistake on their part that the term Semmelweis reaction was coined to characterize people who were willing to dismiss this kind of evidence. In the early part of the last century, patients with syphilis went to mental hospitals until the profession recognized it was caused by a spirochete. And what about just recently, spongiform encephalopathy? People were dismissing that as some kind of cockamamie condition until medical researchers proved it was caused by a prion related to Creutzfeldt-Jakob disease, as I recall correctly. So the point here is that for a non-expert in Lyme panel to recommend to this board, none of the, as I said, without Lyme background, that a physician such as Dr. Jones should be severely punished with monetary fines, probation, and insulting monitoring by a physician who doesn't know anything about Lyme disease for curing 2 patients? Not rational. This is not even a question where reasonable people disagree, it seems to me. It's not rational. When has this board last sanctioned a physician who completely resolved a patient's health care concerns? When is the last time this board has severely punished a physician, for doing well? When is the last time this board has punished a physician for curing patients? And I might add, when has this board allowed the medical establishment to co-opt the Department of Public Health in trying to drive someone with a different opinion and a tremendously successful record of patient care to the fringes? Never. But That's what's going on here. And everything that's taken place in this case, starting with the public utterances of the commissioner through today, support that statement. While the Department of Public Health and the current Lyme establishment pursue this man, he doesn't ask that his pursuers be sanctioned or attacked. He hasn't brought any complaints against them. He accepts that there are to this day two schools of thought about Lyme disease. He agrees that the scientific evidence is not clear or comprehensive enough for one of the other schools to be certified by you at the request of the department. All he is saying, as Galileo did centuries ago under similar sorts of circumstances, is allow me to speak and practice unhindered my honest and experience-based understanding of truth, as I have learned it over these years. In the end, science will tell us both, all, what is right and what is wrong. In the meantime, don't trammel my ability, Dr. Jones says, to treat very successfully the hundreds of people who come to me every year, many of whom are diagnosed with Lyme disease. Don't, in the face of substantial evidence to the contrary, close your minds and your eyes to what is taking place in Dr. Jones's office and the offices of other clinicians who view Lyme the same way that he does. Don't disregard the extensive literature that supports his position. And finally, don't announce a standard of care for Lyme treatment and diagnosis which flies in the face of experience. Do not make the same mistake that the profession has made so many times before in suppressing differing opinions when the science is not clear. Thank you.
Thank you, Mr. Pollack. Thank you, Mr. Pollack. It's typical for us to have to allow a few rebuttal comments. Mr. Tillich, you have 5 minutes.
I'm going to look mostly at some of the facts.
Please continue.
Thanks. I'm going to address my rebuttal mostly to claims of fact, and particularly claims of fact that Dr. Jones cured these children. He says, Mr. Pollack says that the children were discharged in April of 2005. To the contrary, we have this in the record. Dr. Jones's chart, Dr. Jones's letters say that the children have Lyme disease in April of 2005. He continues to prescribe. And indeed, in his testimony, he said the reason he saw them in April 2005 was that they had recently experienced a relapse. Now, nobody else noticed the relapse, just as nobody else had noticed the symptoms in the first place. But clearly there was no cure as of April 2005. And indeed, the children were still getting antibiotics even in 2006 when we began the hearings. S was never homeschooled. We have the testimony of the school psychologist, and we have the school records. The school didn't threaten to expel him. It was one of a long list of considerations. At a time when they weren't sure what to do, they convened a meeting, a planning meeting. They came up with an IEP, an individualized educational program, which included various behavioral modification. And I don't mean that in any formal psychological sense, but behavior planning. That plan was so successful that within 4 weeks they didn't have to continue it anymore, and S was no longer misbehaving at school before Dr. Jones ever even saw him. And we have, this is not me saying so, this is in the school records. It's also in the transcript of the testimony of school officials in the custody hearings, which is also in the evidence. The following year, there was a grading program put into place by which S's grades would be determined solely on the basis of the work he actually turned in, and he'd suffer no penalty for work that he didn't do. His teacher testified that if he'd been graded on normal grading standards, he'd be getting Fs. His behavior was fine, his academic performance wasn't. That's not a cure if your criteria is poor grades to begin with. And again, all of the documentation from people who had no stake in this battle was that these children did not have the symptoms that their mothers said they had, other than S's misbehavior at school. and the ordinary kinds of colds and aches, and bumps and bruises that kids get. That's what the objective documentation was. So, this is not about somebody getting slapped around for curing children because he used some method that the department doesn't like. Let's make no mistake about that. It's also not about big, huge philosophical issues of how do we advance medicine, pioneering, standing up for truth. That's not what this is about. I'll repeat what I said before. Everyone, all of the evidence describes a diagnostic method that is exactly the standard stated in the panel's proposed decision. And Dr. Jones did not follow it. So that's real simple. And I'll leave it at that.
Thank you, Mr. Tillis. Attorney Pollack, would you like to rebut for a couple of minutes?
I turned it off. Record speaks for itself. I don't have anything more to add to my remarks.
Okay, thank you. Now, just it is typical in situations like this where we have a memorandum of decision that, and I'm explaining this just for the audience's sake, that we turn to the panel to get their take on the issues. This panel was chaired by Dr. Fuller, and panel members were Dr. Seneschal and Ann Doremus, so I will turn to the panel now to hear what you have to say, and then we'll field questions from other members of the board. Dr. Fuller, or Dr. Seneschal, or Ann, whoever wants to start.
I'm going to, since I was chairman, boss them around and have John speak first.
I'd just like to make one observation to Mr. Pollack. I don't think he read my CV closely enough. I've been practicing pediatrics and taking care of Lyme disease patients since 1967 in California, Maryland, Virginia, South Carolina, Connecticut. So that's an error in perception. I just want to get that out of the way right now.
Ann, do you have any comments about either respondent or the department's oral discussion today?
I don't have any comments on the oral Sorry.
I got you.
I don't have any comments on the oral discussion. This panel spent a lot of time and a lot of effort and a lot of thought in preparing this memorandum of decision. And we looked at the statement of charges, and I made a brief statement in one of the hearings that we would consider the statement of charges and whether or not the Department of Public Health proved by preponderance of evidence those charges. In the vast majority of the charges, we felt as panel members that there was sufficient proof that the doctor violated the standard of care in one or more of the areas that are stated in the statement of charges. So I feel confident in what we decided. I think it was the right decision, and I stand by our decision. And that's all.
I think it's only fair to take an organized look at the issues that were brought up today, and just to and ask for the board's help on any of those issues, if I can kind of bring them up one at a time. And I'm more comfortable with this than anybody, because I've been doing this for what, a year and a half or something. So I getting pretty comfortable with this case and this audience and the enthusiastic support. So I'm pretty comfortable here. One thing I wanted to ask of my co-panel members is if they felt whipsawed or manipulated by the medical environment in their decision making at all.
I did not.
Absolutely not.
Yeah, I didn't feel that way either, and it's it may be an external perception that I got treated that way, but I don't feel like I was treated that way. and I don't feel like I was manipulated by any external forces. I felt like my head was in the evidence that was being presented and the testimony that was being presented, and that's what I used to help make my decisions here. I'd like to ask the attorneys if I can just get a sense for a second, because there were so many motions that were parried back and forth over the course of a very long time. We had to make a list of attachments, and we may well have omitted one just because there were so many. But I think that the department and the respondent, and I'd like to be clarified if you don't feel that way, either of the attorneys, had a fair chance to have their motions respectfully considered, and that although the rulings may not have gone in either direction that they may have preferred, that they were at least objectively, justly thought out and generous. Did you feel differently? Do you feel differently, Attorney Pollack?
I certainly would not challenge the fact that the panel treated Dr. Jones and me with respect. That was never a question.
Oh, and that the motions that we considered were given good thought and were treated in a just and generous fashion. I felt like we were being very just and generous in all of our motion decisions, and I just want to see if you think otherwise.
I cannot, in many of those matters, we were asked to leave the room while you received legal advice. I don't know what went on in the room. I am not privy to your thought processes. My sense was that you tried to do the right thing in a number of decisions, though we do strongly disagree with, but we're not here to rehash those today.
No, that's for sure. If you thought they were unjust or ungenerous in some way, I think that it'd be nice for you to state that. I think that from my standpoint, we allowed a lot of flexibility, is what I saw.
I think the panel tried to be fair, and I think the proof of the pudding is the final result, and it's a result that is very, very seriously flawed, in our opinion, with all due respect to the panel and the tremendous amount of time and effort that went into the process of making the decision.
Okay, so I'll take the department's request to modify items. Again, I appreciate any board input or questions at this point. They want us to modify paragraph 4. This is something we're pretty used to doing. It's kind of casual for us. So let's consider the modifications they proposed to paragraph 4. They would like us to do 3 things. They would like us to have the monitoring start sooner. They would like us to have the monitor be board certified in pediatrics. And they would like the monitoring to somehow, or I forget the words he used, but adhere to some standards that were brought about in this decision. Any thoughts from the board?
Yeah, I have no objection to changing it in that regard. Increased monitoring certainly doesn't offend this board.
Any other ideas from other board members? We welcome your thoughts.
I also just want to say that the time frame that the department stipulates is both prudent and appropriate, and the point of using someone with the experience of pediatrics is also appropriate in this matter.
Rob, it's typical for the board to kind of look to the panel for guidance on this as well. What do you think?
My only thought is on the fact of a pediatrician. Should it be a pediatric infectious disease individual? Now, that may be going too high, but if Dr. Jones is considered an expert in a specific infectious disease, maybe it'd be better that he be monitored by somebody with an equivalent expertise. So that's my thought on that.
I think there are very few physicians in Connecticut who are both board certified in pediatrics and pediatric infectious diseases, and I suspect there may be some conflicts of interest among that small group, and that's why we didn't ask for it that way.
I have an opinion, but I'd like to hear more.
It seems to me that a regular pediatrician would actually be preferable to the extent that they have a broader view, they have more sense of what the differential might be, and they would be entertaining everything.
Yeah, that's a good thought. I think that having the monitoring starting sooner, considering we're like years down the road, I really don't want to quibble about a handful of days. And although it would be neat, I think that you might actually need a little time to line up the right person. And I personally don't mind those 60 days, unless the board or the panel felt strongly about making it tighter. The board certified in pediatrics, I think you're right that a broad view from a pediatrician would be nice, and that it's going to be tough to find someone down in that corner of the world. And I as far as this standards notion, I don't think that needs to be included in that paragraph or any paragraph. Personally, I don't find that necessary.
Do you want to make a motion to modify the language in the MOD to reflect your comments, and then we'll see?
Okay, that's a good idea.
We have two other.
Yeah, no, we've got two other things. So let's close this paragraph 4 question first. I move that the monitor be board certified in pediatrics as a modification to paragraph 4 of the MOD.
I'll second it.
Is it going to be, you're going to make each issue a separate motion?
That's the only motion I'm going to make.
Okay, all right.
Personally.
So we've got a motion to modify the monitor to a board certified pediatrician, and that's been seconded. Is there discussion on that motion?
That's the key. That was the most important part.
No further discussion on that motion. I'll call the question. All those in favor of modifying the MOD the way Rob just said, just signify by raising your hand. Anyone opposed, recused, abstained? Dr. Lindbergh is abstained. So, okay, why don't you go on, Rob?
Thank you.
Well, before we go on, Dr. Hanks, did you have a question that you were going to ask?
No, sir, not at this time.
Okay. Go ahead, Rob.
Good idea. I have the second one that we state expressly findings of fact 11 and 16 that there was a violation of the standard of care. If you could all turn to page 5 and 6 of 16, you'll find 11 and 16. Our finding of fact states in 11, respondent failed to reconsider his diagnosis of the disease for which he was treating SS in light of a negative Western blot test obtained in April 2005. And a similar sentence for ES. And the department wants us to say that that's a violation of the standard of care, and I'm not prepared to say that. But I'd like to hear if anyone else in the panel or the board would be prepared to say that.
No, I'm not prepared to say that either.
Nor am I.
So unless anyone from the board wants to have further discussion about incorporating the department's change or wants to make a motion, I say we move on.
Any other comments from the board members? Okay, Rob, why don't you proceed?
The third thing that the department has as a request is to substitute a finding in favor of the department for fact number 8 and 15. That's on those same page 5 of 16. The facts are very similar. In 8 reads, respondent considered a differential diagnosis in his care of SS, and 15, the evidence is insufficient to establish the respondent failed to consider a differential diagnosis in ES. I think they mean the same thing, kind of one's written as a double negative and one's written as a single positive, but they're basically the same sort of thing for the ES and SS. The department wants us to find in favor of that, and I wonder if the panel has any need to consider our original finding of fact.
No, I do not have a. You just drew. Oh, sorry. No, I think that when we were considering this, we gave it a lot of thought, and we did feel that he did have a differential diagnosis, or at least entertain a different differential diagnosis.
I will reiterate that the three of us considered this very carefully and came to this conclusion that he did entertain it.
Yeah, and for those of you that aren't familiar with all the evidence, like I am, there were many tests for other diseases that were ordered at that time, and so we considered the ordering of those tests a consideration of differential diagnosis, and therefore didn't find the evidence to support that finding. So unless anyone wants to make a motion about the department's position on that.
Not necessarily.
Okay, that was three things to look at. The respondent's response to the panel's MOD is slightly longer, has more sections, and requires a little help. I wonder if on page 1 of that response, paragraph or section 2, it's titled "It's improper to use preponderance of evidence rule." I wonder if I can ask my colleague to take a look at that, and I'm looking at you.
Okay. What Attorney Pollack has asked for is for this board to apply the clear and convincing evidence rule rather than the preponderance of evidence rule. This was raised and briefed extensively by both sides at the beginning of these proceedings. I believe Attorney Pollack raised it as a special defense. And what the case law says is that in an administrative proceeding, the law is very clear, actually. It's the preponderance of evidence standard. So I disagree with Attorney Pollack on that point. And just so the board knows, the briefs and the extensive oral arguments and the board's ruling are in evidence on that point that was raised, I think, at the very beginning of these proceedings.
I wonder if you have any comment, because I have no personal public knowledge of stated positions, because I don't pursue that kind of knowledge. That's section 5. Is there any reason why we should be compelled to have this considered?
I don't believe so. I think what I'm relying on is Attorney Tillis's characterization of what the charges are intended to do. And I think in drafting the decision here, the panel, wherever possible, took out the term Lyme disease and noted that where it found violations of standard of care, it was more general standard of care, and actually used the term a disease in place of Lyme disease to address this issue, and I think that was a good thing.
I don't think I personally have any more questions, or comments to make directly to that response, but I'd be happy to, if anyone has particular interest in that response or section of it and wants to talk about it, I'd certainly love to hear your thoughts about it.
Are there questions from other board members for the panel? Dr. Wolf?
Without rehashing everything, obviously, that can't be done in your statement, where you said clearly you have more comfort with the information than we do, since we weren't exposed to it. So as a result, I'm going to have to rely on the panel's judgment. But I was wondering if you possibly could distill for me the crux in your mind of the issue, because the one thing that has been bothering me throughout, for what little I know of the process, has and is somewhat distilled by Attorney Pollack's statement, is the issue of that the medical profession will at times find out that after the fact that what, quote unquote, as he said, a maverick was perhaps right. And one of the things that came to mind even before he said that was the whole issue of H. pylori, and there's certainly plenty of other examples in medical history. So, and I get the feeling that that's not the issue. I've looked through all the paperwork, but I was wondering if you could perhaps, in a few sentences, distill the major issue.
I can't, but I can try. And I don't know if maybe
I knew you could.
I don't know if maybe someone else wants to try to help Steve with that, and I certainly, it might take all of us to pitch in for a little bit to get to that.
The crux of the issue, again, is the statement of charges, and that the doctor prescribed medication for children he hadn't seen, he had no medical records on, and solely on the advice of the children's mother. And he continued to do that, and continued to prescribe that medication in lieu of the fact that there was no positive evidence that the children had Lyme disease. There was no blood test that proved it. In our opinion, there was no evidence that the children had Lyme disease. And he continued to prescribe medication and treat these children before he had seen them. And that was, I felt that was a very important issue.
I think that there were a lot of different pieces floating around this, and there's no doubt that it's complicated. But I think ultimately we spent a day, for the physicians and statisticians, we spent a day talking about pre-test probability, Bayes' theorem, weird, esoteric concepts in medicine, but basically the more likely you are to have the disease before the test is done, the more likely the test is to have some value. And we spent a lot of time talking about where ticks live and don't live in our country, and that really went to establish, I think, pretty well evidence-wise, that there was a very low risk in this particular family, especially compared to a family, say, that lives in Connecticut or Pennsylvania. It's a very low risk as far as tick exposure goes, and then it all follows from there, low risk and non-specific and other things that don't confirm it. I think ultimately you end up at a pre-test probability of making the right diagnosis that gets so low that it becomes almost absurd. Doing that alone is not such a problem, but doing it remotely was very problematic for us. And there were other issues about the care, which was difficult to really pin down, but it was hard to get the children followed in their native environment for some reasons also. It just all coalesced in this. Again, there's certainly some social and interparental issues that brings it to light, and there certainly continues to be a lot of friction among the parents, and we had a hard time as a panel, if I can speak for them, separating the difference between that family friction and disease presentation. It became very, very unclear to us about where that line was drawn. I do think, taken point by point and charge by charge as the department brought it, and as we combed through evidence and weighed people's testimony, I think a similar panel would come to a similar decision.
Okay, thank you. Dr. Seneschal?
Would it be possible for you to make a brief comment in light of the discussion of the panel?
Just went off. May I be permitted to make a brief comment? Sure. Thank you very much. Actually, two comments. Number one, Ms. Collier pointed out, Dr. Seneschal, I just wanted to explain to you why I made the comment that I did about Lyme experience. During the hearing, you said you had treated 40 Lyme patients in your career, and that's what I was reflecting on. So it was in March 23, 2006 at page 152. The other point I'd make is that the discussion that the panel is engaging in with the rest of the panel, the board members now, I think, is really making the point that I brought up, which is the standard is being set and the clinician is being second-guessed, and there is a total lack of, not total lack of, but there's a lack of grappling with the evidence that the clinician said he relied on: history, tick attachment, and clinical experience. And this is the swamp that I suggest that you're run the risk of wading into here by trying to set the standard of care in the face of so much conflicting evidence and lack of concurrence in the medical profession about how this system works, this disease system works.
Okay, thank you.
Thank you.
Dr. Goldenberg.
Mr. Pollack I've read the MOD several times. I've looked at all the arguments on both sides, and I have to say I'm going to take the opinion that your argument has more holes in it than a watering can. And I'll tell you why. I'll try and take them piece by piece, because I think we need some leadership on this issue, and I'm afraid I'm going to put myself in the position to do that. You mentioned a lot of points about how the board reaches its decision, the board's qualifications and issues of that, and each of the arguments you raise can easily be argued with and trodden upon, I should say. The first thing you state over and over again is that this board is attempting to create a new standard of care for Lyme disease. In fact, that's not the case. What this board is trying to do, quite clearly, is reapply the existing standard. And the reason I say that is because between us on this panel, though we may not be Lyme specialists, there are literally hundreds of years of experience in treating patients, and the standard of care of treating a patient does not change depending on the diagnosis within broad medical standard. And it is obvious to me that the standard of care was broached not one but many times in this case, and the evidence that's presented to me today that I've heard in the arguments is actually compelling and clear. I have no issue with Attorney Tillis's argument. I think the case has been made very clear by the Department of Health. Again, to reiterate, I don't think that the standard of care is being made new here. I think the old one is being reapplied appropriately. The second thing I'd like to say is your incredible remark about the historical records, as if Dr. Jones is holding up a sword and a shield and needs to be put on a pedestal. And the examples you give, historical arguments about other diseases that may have been treated by mavericks. You can name several examples of diseases that have been treated by mavericks, and I'm sure the records are full of thousands of people physicians who treated patients inappropriately with experimental drugs outside the bounds of normal medical care, and probably injured thousands of patients before the truth was finally uncovered. So you're using the example that there may be some diseases that eventually became uncovered with research, and using that as an argument to support his standard of care is worthless, because the history is full of enormous numbers of examples where medical care was rendered inappropriately and turned out to be dangerous and unnecessary in the end. The other argument you make, which is full of holes, is the fact that the board members themselves may not have specialty knowledge of Lyme disease. The board frequently hears cases where we do not have specialized knowledge of a particular subspecialty. We hear cases brought against obstetrics and gynecologists, against psychiatrists, against internal medicine doctor. There is nobody on this board who has global knowledge of every single subspecialty. So demanding that we come to that standard is inappropriate. We're all practicing physicians. We know the general standard of care, and I think it's fairly easy for us to recognize when that standard of care was broached. The next issue you raise, and one of the major issues that has not been brought up, is that the purpose of a differential diagnosis and the purpose of clear diagnostic workup is the question of risk management. That's what this is about. It's about risk management. And the reason I ask that is, let's say for argument's sake, one or both of these children had cancer, for example. Let's say they had leukemia or lymphoma. How would the treatment that was rendered by Dr. Jones and a differential diagnosis he created picked up those diseases? The reason why we make a differential diagnosis is to distinguish those patients who can be treated from those who can't. And in this situation, I believe it's the board's opinion that other diagnoses could have been missed. And I believe it's the board's position to manage the risk, to be an advocate for patients, particularly the pediatric population, to prevent this kind of behavior. That is part of our job here. Part of our job is to assess, is to protect the population wherever we can, and to reduce the risk. This kind of behavior, at least in my opinion, increases the risk. It does not diminish the risk. The last point I'd like to bring up, a very good and clear one, is your constant reiteration of the fact that Dr. Jones cured these patients. That quote, and we put that in quote, cured these patients. It's just an obnoxious remark, and I'll tell you why. The reason is because your first-year medical student, your first-year resident, understands quite well and quite profoundly that just because you start a therapy and the patient gets better, you cured them. That's nonsense. The two may have nothing to do with one another, and they may not be related in any way. Just as when you start a therapy for a patient, and the patient dies a miserable death, that you caused that death. You may not have. The disease may have progressed. So this whole idea that he cured these individuals is worthless. It's a worthless argument. It's statistically improper. It's got nothing to do with the modern practice of medicine. It's a complete violation of everything we know about cause and effect in disease. So for those arguments, the fact that we're not creating a new standard of care, we're reapplying the old one, the historical records do not bear out the behavior of mavericks, and in fact is generally pejorative to the behavior of mavericks. Second of all, we don't need to have specialists on the board because we're all practicing medicines and understand full well the standard of care. 4, the application of the standard of care is about risk management and protecting the pediatric population. And number 5, we don't believe Dr. Jones cured anything.
Okay, thank you, Dr. Goldberg. No, thank you anyway, Attorney Pollack.
I think that since those remarks were addressed to me, and then since
no, excuse me, Attorney Pollack, you don't have the floor.
I realize that. I'm asking for your permission to speak.
And I'm saying we're going to continue our deliberation.
All right.
Dr. Hanks.
Thank you, Doctor. I don't see that there's anything in the proposed MOD that contradicts previously stated positions of the department or the commissioner on the specific issue of how you diagnose Lyme disease or the specific standard of care as it relates to Lyme disease. And from my understanding of what the department has said is that they're not going to make a determination. And I don't see that that's what they've done with this MOD. Rather, I think the department is concerned appropriately with the general approach this licensed physician undertook in assessing, diagnosing, and treating these children. For that reason, I'm in support of the MOD as with the recommended modification by Dr. Fuller.
Are you making a motion?
I believe that is currently the motion that's on the table.
There's no motion on the floor.
Well, then I would forward that motion at this time.
Do I have a second to the motion? I understand the motion to be
the memorandum as presented with the modification presented by Dr. Fuller for it to include a board-certified pediatrician as the monitor.
And you're moving approval of that?
That's correct.
Do I have a second for that? Okay, is there discussion on the motion? Hearing none, I'll call the question. All those in favor of approving the MOD as modified by Dr. Fuller and moved by Dr. Hanks, please signify by raising your hand. Opposed? Recused? Abstained? Okay, the motion passes. Thank you very much. I would like to, just as a postscript, as again is customary, I'd like to thank the panel for their time and effort in taking care of this case for us and for spending the time elucidating the points during this meeting. So thank you very much, and thank you again for Dr. Seneschal for coming and visiting us today. Is there any further business to come before the board today? If not, we're adjourned. Thank you very much.